I'd like to talk today a little bit about how to find candidates for LAA closure. And I'll start with talking really about the problems we have today with undertreatment and underestimation of atrial fibrillation, which might be one reason why we think this treatment might not be so common. But if we follow guidelines and if we really were aware of all patients who needed anticoagulation, as been alluded here before, this problem might be more significant than we had thought before. We try also to find how many potential patients are there and how to find them. I'd start with talking something else, a little bit about the prevalence of atrial fibrillation. It has usually been considered according to the European and American guidelines, to be about 0.8 to 1% of the adult population. However, these numbers are based on quite old studies. They are not using representative populations, and older patient groups are often excluded. This is data from the Swedish National Patient Registry, and we found 209,000 patients being alive with a primary or second diagnosis of atrial fibrillation that had been to hospital. This is equivalent to almost a 3% prevalence of atrial fibrillation in the adult population. So it's about 3 times higher than what has been previously published with regard to this. As you can see, there is also a problem here that we have a clear undertreatment of warfarin. And this is especially significant for women, which is a bit paradoxical, since we know that women, irrespective of age groups, always seem to run a higher risk for stroke compared to men. So not only do we have undertreatment, we have an undertreatment in the patient groups where the risks are the highest. In order to prevent strokes, we have a very effective treatment, oral anticoagulation, which prevents about 67 to 70% of all stroke cases. So it is a problem that we, despite this effective treatment, which might be the most effective we have in our toolkit, we still are undertreating so many patients. It has been debated whether the bleeding risk is so significant that we should avoid anticoagulation treatment. This is data from a risk-benefit analysis published in Circulation last year. And what you can see here is that we see that despite we have a high risk for bleeding or a high risk for stroke, the benefit of anticoagulation treatment is almost always larger than the risk for having a serious bleeding. So there are many reasons why we in general try to avoid oral anticoagulation treatment. We think the patients are too sick, they are too old, they are falling a lot, and those old patients don't manage dosing. The doctor or the patient is afraid of this treatment, and many consider that aspirin treatment is a better alternative. I'd like to discuss some of this prejudice regarding anticoagulation treatment. This is data from the Swedish National Register Auricular on atrial fibrillation. And here are the INR values, the time and therapeutic range with respect to different age groups. And this is based on now 80,000 patients and 2 million prescriptions. And as you can see here, there is really no relation between age and the low therapeutic range, rather the other way around. The older the patient is, the better the INR is. This is also a common reason why we don't start anticoagulation. The patient is falling, and therefore the risk for a serious bleeding is increased. This is data from a study from 1999 stating that persons taking warfarin must fall about 295 times a year for warfarin not to be the optimal therapy. So I think maybe falling is a bit exaggerated reason for not prescribing anticoagulation. However, there are patients where oral anticoagulation doesn't work. This is a patient I saw a couple of weeks ago. It's a 74-year-old man, physically active. He has a paroxysmal atrial fibrillation, hypertension, and diabetes mellitus type 2. A couple of years ago, he was receiving radiation treatment for a prostatic cancer, and he's now doing fine. He has a slight renal dysfunction. His CHA2DS2-VASc is 4, and due to that, he was prescribed warfarin. He started then to bleed from his rectum and his bladder, probably due to radiation damage of his tissues. We then changed his medication to rivaroxaban, 20 milligrams once daily, and he got new bleedings, and then we started with the lowest available dose of dabigatran, 75 milligrams BID. Still, the patient was bleeding. So the treatment alternative here is now, should we stop anticoagulation treatment? Should we replace it with aspirin? Or should this patient be considered for a left atrial closure device? According to the guidelines, we should consider a left atrial closure device in patients with a high stroke risk and contraindications for long-term oral anticoagulation. I think this patient gives us an example of how these patients can be. So maybe we have also other candidates, high-risk patients for stroke bleedings during oral anticoagulation, as the patient I presented, and also patients who have strokes despite effective oral anticoagulation. How sick then are our atrial fibrillation population? This is based on a paper from Friberg, European Heart Journal last year, from 182,000 patients. The mean CHA2DS2-VASc score of these patients is 3.7, which is equivalent to 8% stroke risk per year. On the other hand, they also had a mean has-bled of 2.5%, which is 2.2, which is equivalent to a 2.5 risk for major bleedings in with the oral anticoagulation. So this is a Scylla and Charybdis trial, a high risk for stroke when using, if we don't use oral anticoagulation, but also a high risk for bleeding. I would like also then to focus on a special group of patients, namely those who have atrial fibrillation and renal disease. This is data from a Danish study, Olesen, in New England Journal of Medicine this fall, and he presented 132,000 patients from the Danish patient registry, of whom 2.5 patients, more than 3,500 patients, had a non-end-stage renal disease. And as you can see, these patients had quite 90% of them had more than 2 points in the CHA2DS2-VASc score, and 38% of them had more than 3 points in the has-bled score. So again, a group of patients with a high risk for stroke, but also many risk factors for bleeding. And we know also that renal disease in itself is a major risk factor for bleeding and stroke. You can see that it's almost a doubled incidence for stroke in this group, and more than a doubled increase for bleeding. So patients with renal disease are really a group that we should consider. Also, we should remember that antithrombotic treatment in this patient is effective. So it's not that we should avoid anti-oral correlation, but we must keep in mind that these patients do have a high bleeding risk. How often then is it that we have to stop oral anticoagulation due to bleedings? This is data from the southern part of Sweden, from a center who has about 6,000 patients on oral anticoagulation due to atrial fibrillation. The annual bleeding rate in this material was 2%, equivalent to 120 patients. Of these, 1.6% of the patients, equivalent to 90% patients, did not have an intracranial hemorrhage. Oral anticoagulation could be reinstituted in 40 patients, and the remaining 50 patients, about 1% of the material, had to be left without oral anticoagulation, which sort of indicates the annual rate was 50 patients in this area of patients that could not take oral anticoagulation despite a high risk for stroke. Another case, a 65-year-old male, diabetes and hypertension. He has a TII and comes to the hospital. He has a previously not known atrial fibrillation. Warfarin is started and he's discharged. 3 months later, he has a new stroke with hemisymptoms. The INR is completely normal, and the patient has a partial neurologic recovery, so he's almost fine when he's discharged again. But, of course, this can happen again. And what is our treatment alternatives? Should we add a thrombocyte inhibitor? Should we change to another oral anticoagulant? Should we combine an anticoagulation drug with clopidogrel or some other thrombocyte inhibitor? Or should we consider this patient for a closure device? How common is this phenomenon? This is data from the Swedish Stroke Register, which includes about 26,000 patients with ischemic stroke every year. Of those 26,000 patients, 6,000 strokes were in patients with atrial fibrillation, and of those, 17% were treated with oral anticoagulation. So they had correct treatment, but they did have strokes anyway. So this is also a significant patient group. So in conclusion, I would like to state there is a high prevalence of atrial fibrillation in the adults. And this will make this, if we start to follow guidelines, we will maybe get rid of undertreatment, but the number of patients who are potential bleeders will of course increase. This population has a high risk for stroke, approximately 8% a year. And despite that, we don't use our verified effective treatment. About 2% of the OIC patients have a major bleeding every year. And in patients with renal disease, this increases to about 9% a year. And 17% of all ischemic strokes occur despite adequate treatment with oral anticoagulation. So in summary, this is quite a large patient group. So where to find them? In many parts of Sweden, we have centralized anticoagulation clinics, which give us usually a better quality of anticoagulation treatment, and we could there also easily find bleeders despite patients who bleed during OIC treatment. Stroke units should be able to define or identify patients who do not respond to oral anticoagulation. And nephrologists, I think, is a special group which to focus on, because there we have patients with often a very high risk for bleedings and stroke. Thank you very much.